So good morning. I've been asked to talk to you about anterior circulation aneurysms. And there's some slides, but there's a bunch of videos at the end, and we can talk through the videos. I think the way Dr. Harbaugh approached the carotid actually is probably a much better way for you to understand, and then we can go back to the videos. Our thing isn't working. Yeah. Yeah, downstairs to the lab to teach. Do we know if we can get the remote working? I'll do it by hand for now. Here's my disclosure slide. So always with, if we're talking about, I mean, I know you're here, there's an embo part of the course, an open part of the course. You know, how do we decide when we're going to do an open operation? So first of all, is something unsuitable for endovascular coiling? The location of the aneurysm. You know, in my practice, a lot of the basilar tip aneurysms are treated endovascularly. And there's a lot of variability. There's variability in the anatomy. There's variability in aneurysm projection. There's what the dome of the aneurysm looks like. Does it look like, you know, you're going to have to reconstruct a whole bunch of branching vessels? And I always operate on patients that have hematoma. I think removing a hematoma allows patients to recover more quickly, particularly a large hematoma, and it also gives you a very quick way of dissecting. So when we talk about the principles of aneurysm surgery, you can apply this to any type of aneurysm. You have to understand the anatomy, all right? So there's an anatomical foundation, and you have to have a complete understanding. So if you're in the middle of operating on, say, an A1 aneurysm, and the patient has a patent communicator, well, maybe if you get into trouble, you can take down the A1 and trap the aneurysm. You would have to know that going in. And so operative planning is a very important step. And your technique, I learned this when I did my fellowship out in Phoenix with Dr. Spetzler. Meticulous dissection. Take your time, expose everything. When you get the experience of a Dr. Harbaugh doing a particular type of operation, then you can ramp up the speed. But in the beginning, when you're learning how to do stuff, take your time. And always have some type of intraoperative vascular imaging. You'll see in one of my videos, I can do intraoperative angio pretty quickly, but you know, indocyanine green, some type of way of knowing that the branches and everything are filling and the aneurysm isn't when you're done is incredibly useful. Do we have any technical support to try to get our thing going? So again, back to our anatomical foundation, we have basic brain anatomy and function, knowledge of the relation of the vascular anatomy and brain structures. So what vessels supply what territory is all quite useful. And as I mentioned in that sort of A1 example, knowledge of collaterals. I mentioned yesterday with our collateral discussion when they were talking about that distal MCA aneurysm and potentially trapping that. You would only know that, and we never, or we very often don't take advantage of the natural collaterals that are available. So knowledge of vascular collateral circulation is very, very important, particularly if you get into trouble. And so really with aneurysm surgery, you know, aneurysms can rupture, vessels can fall apart. Your ability to get out of trouble will, you know, obviously impact your outcomes for your patients. And specific vessel tolerance, which vessels can tolerate temporary clipping and for how long. You don't want to leave a temporary clip on, you know, for 45 minutes because the patient's going to have a stroke. And so you have to know all these things beforehand. Some general things about operative planning, positioning. You know, when you bring in the patient, depending on the type of aneurysm, how far lateral you're going to have it. For an anterior communicating, maybe that 15 degrees. Whatever it is, review the case beforehand, look at the aneurysm, look at the direction that the aneurysm is pointing, and try to come up with how you're going to position the patient's head. The approach in the craniotomy. This is the area that's changed the most in my practice over the last few years. When I was out in Phoenix, we did a lot of orbitozygomatic approaches. When I came back, I basically did some of that for a period of time, and then I switched more to a general terional type of approach for most of my aneurysms. Obviously, for some types of basilars, you're going to go subtemporal. But one of the things I've been doing a lot now are these sort of mini cranies through eyebrows, and most recently through a blepharoplasty incision, and I'll show you some of that video. But But this is sort of variable, and you can tailor that to the case and to the patient. Ventriculostomy. In patients that have had a subarachnoid, obviously, well, many of those patients may have a ventric, and you can drain off CSF. What I like to do if I get in the brain is full is just sort of use the Bajer-Sampson little point and drop a ventric in, drain some CSF, and that gives immediate brain relaxation, and you're not fighting the brain. I don't use any retractors when I do aneurysm surgery, and so having that CSF drained allows a lot of brain relaxation so that I can get the exposure that I want. And then sort of the sequence of operative field exposure. If I'm going for a middle cerebral artery aneurysm and it's unruptured, I may just open the fissure right over where I think the aneurysm is, go down and clip the aneurysm without going down to the carotid. That's not the standard way that you're taught. Everyone says go down, open up the optic carotid cistern. Usually that's to drain CSF, but also to provide you with proximal control. But I think as you get more experienced, you can sort of tailor yourself and go right to the aneurysm if you feel confident enough that you'll have the kind of control that you'll need. And then again, branching vessel and aneurysm neck, presentation. How you're going to have those all laid out before you place the clips on. Here's the thing. Is that? Yeah, you got to plug this in. Oh, you see, I didn't know that. See, now the whole presentation changed. I threw this slide in, again, partly because I'm a guy that does both, but partly because I can't tell you how many places I've gone as a visitor or at conferences, and you hear some really, really experienced, well-known neurosurgeons looking at an angiogram, and they can't read an angiogram correctly. I mean, yeah, they can pick out the pathology. Everybody should know how to read an angiogram, and you learn how to read an angiogram by spending time looking at angiograms before you do your procedure, and you'll pick up a lot of stuff. And the way you learn about how to read any kind of imaging is you see so much normal anatomy over and over again that when there's abnormal, it stands out. And so think about that for a second, but always start with your standard views. I mentioned this yesterday. AP and lateral views. Someone shows you oblique and things like that, say, can you give me the standard views first? Go back, look at your AP and lateral, then get into your funky views. Okay? So that's your AP and lateral. After you've looked at those standard AP views, then you can start looking at your oblique and fancy projections. And then at the end, always that 3D rotational angiogram, those 3D CTA type images, they're really, really fantastic. But there's one caveat about them. They are limited by whoever created them. So those images can be manipulated and windowed. And so you may lose infundibulum, sometimes become small aneurysms, things like that. So an infundibulum, obviously if you window it, you can window out the vessel. You can window out parts of an aneurysm, a small dome. So just be wary when you're looking at 3D angios that somebody has created that may not be the person that's doing the procedure, and they're trying to make a nice image for you to look at, but you may lose some information in that. So just remember that. I don't have to go back anymore. So just for the anterior cerebral, remember that A1 portion is that pre-communicating or horizontal segment. I'll show you an aneurysm very proximal on the A1 today. Begins at the ICA bifurcation and ends in the ACOM. The A2, as you know, is that post-communicating part, and obviously you need to lay out all of this stuff. If you're just clipping an anterior communicating artery aneurysm, you're really not worrying about A3 through A5 divisions of the vessel. But if you're talking about pericallosal types of aneurysms, then you're more worried about this than you are the more proximal branches. It's just part of that knowledge of the general vascular anatomy. So for clipping of anterior communicating artery aneurysms, you want to see both A1s, both A2 vessels, obviously the communicator. Sometimes if you get into trouble, you can try to close the communicator, but remember there's a lot of perforators coming off of that. So most of the time you're trying to preserve the ACOM itself. You want to see the Hubners. These are very, very sensitive. They don't tolerate temporary clipping very much and any kind of spasm. So when you see Hubner, sort of lay it out a little bit. And then sort of these orbital frontal polar and perforating vessels, you want to be wary of them when you're doing your clip or clip reconstruction. Just some general pictures of anatomy pointing out the different vessels. Here's our, sort of pre-communicating A1 and our post-communicating A2. The ACOM is there, small aneurysm there. And it's hard to see, but you can see coming right off the A2 there in its classic position is the recurrent artery of Huebner. Here's a blow-up of a 3D a rotational angiogram. And again, A1, Huebner coming off, usually most of the time coming off of the proximal A2. It goes in the direction of the A1. In fact, often when you're doing your dissection and you put in, you start to retract and you're looking under the scope, the first branch that you often see is Huebner. And you can follow Huebner right back into the complex. You often see it before you find the A1. And there's the opposite side, and then orbitofrontal branches are usually going in the opposite direction, and of course your aneurysm. So for the MCA types of aneurysms, and again we're sort of talking about anterior circulation in general, so you have that M1 horizontal or sphenoidal segment. Just be wary of the perforated branches or lenticular striates that arise in this area. You have your M2 or insular division of the vessel, M3 and M4 opercular and cortical segments. I'm just trying to get us up to the point of the videos. Just sort of a slightly oblique. So this isn't your standard view, right? So we start with your standard views, but when you start getting into your obliques, you can lay things out the way you need to see them. So general aneurysm technique, and sorry that was sort of cut off there on the bottom. The standard teaching is opening the arachnoid over the optic nerve and carotid artery, or in an MCA, alternately opening over the distal sylvian fissure. I tend to go right to the aneurysm now for my unruptured aneurysms, but I wouldn't suggest that you do that early on. For the MCA, follow in the internal carotid up to the bifurcation, and then walk along the M1 to the bifurcation or trifurcation. If you get lost, that's the simplest thing to do. For the ACOM, you can identify A1 if you can, but Huebner is often that first vessel that's seen. Retraction, you have to be very careful when you're placing retractor because, like I said, Huebner is very, very sensitive to manipulation. When you see Huebner, when I'm done with the case, I always put a little capacitor on Huebner just to avoid any kind of injury with it. Try to open up your arachnoid planes, interhemispheric, to give you exposure to the A2 and the ACOM. And obviously, when dissection is inadequate, take some gyrus rectus. I try not to take a lot of gyrus rectus. I try not to take a lot of veins. But if a vein is limiting you, obviously you can take it. And if you can't really, for whatever reason, the aneurysm and the complex is embedded in the brain or it's rotated on its side, then obviously you might have to take a little gyrus rectus if the patient is fine. Okay. So with clipping, you want to mobilize and to tether the dome, any kind of arachnoid adhesions or vessels that are adherent to the dome. We talked about being wary of anything that plaque or things like that in the vessel wall and hematoma, and obviously branch vessels that are adherent to the dome. You don't have to spend a lot of time taking that branch vessel off the entire dome, but certainly in an area where it may be compromised by the clip. In a lot of cases, less is more. I know a lot of people take a lot of time dissecting things off. For me, I like to get in, treat the aneurysm, and get out. So this is our first video. I'll show you this. So I've been doing these eyebrow type incisions. Here you see a small aneurysm in a patient with a family history of subarachnoid. Initially was followed and had one dome. We followed it conservatively, and then over a period of 2 years he developed a second dome. So we decided to do this through eyebrow incision. My plastic surgeon comes in and sort of maps out where the supraorbital nerve is. It's a very small incision. It's a little local. And what I find about these small approaches, first of all, once you get used to them, there's the anatomic keyhole, you're going to make a little burr hole there. But once you get used to doing them, it really gives you the same exposure that you would through a much larger craniotomy. Remember, when you're doing an operation, you're really working in a very small space. The first one of these that I did, I got into some bleeding. And I started, I was cursing myself for using this approach and all that. But when it turned out, when I actually wound up, putting the scope in the area to fix the aneurysm, it was the same position it would have been in had I had a much bigger exposure. So this is the room that we use here at NYU. And I have an intraoperative angiogram. We bring up the preoperative images beforehand. This is my chief resident sitting down, about ready to put the aneurysm with me. So first we start here, you see the dissection. With the eyebrow incision, we do go and open up over the optic first just to get some CSF out, because that's how you're going to get the relaxation that you need, because it is a much smaller cranium. You need to get a little bit more brain relaxation. As I said, I don't use retractors, but in this situation, you can't get a retractor in there because it's only a 1 centimeter plus craniotomy. You can start to see a little bit of the dome here being laid out, okay, and then just opening the arachnoid over the aneurysm. And you can see the one lobe, there's the other lobe. You can see a Huber vessel being draped over the top there. Looking underneath the other dome. So this is the chief resident putting a little clip on the neck of the aneurysm. When you're learning, I always sit down next to the chief and I take a look around, and I thought that the aneurysm was still filling. And so you'll see how I move the clip a little bit for him. Dr. Tanweer, Omar, here in our room, he clipped his first aneurysm this week, and of course I had to do a little bit of manipulation, but that's how you learn and get it done. So once we clipped the aneurysm, I made a slight adjustment on where my chief had it in. You can see that tiny little opening on the patient's head. We bring in our Zigo machine. It literally takes us 4 minutes to do an angiogram. You can see the machine positioned over the head. The interventional fellow is doing the angiogram, and you'll see right away we get the information that we need. We put in a sheath at the beginning of the case, and you can see we're just checking right away. We get a beautiful digital image. We know that the aneurysm is clipped, and we're done. See? Aneurysm is gone, everything's going normally, and we then pull out the Zigo, and we're done. So in this case, obviously I didn't do indocyanine green, just because we have this fantastic piece of equipment. And then you just pull it out and close. The closure takes a couple of seconds. You close the dura, pop a little piece of bone back in. Sometimes you use a little methyl methacrylate to smooth out the bone, but that's the incision. It's a little nothing. These patients go to the recovery room with a Band-Aid. Almost all of them go home the next day. It's like a 23-hour mission, just like a carotid. So let's look at another video. So here's another ACOM. This is, I think, through a regular pterional. The interesting thing about this case is that this patient has a trifurcation. So he had one dome filling from one side and another dome filling from the other. So there are 3 vessels here in the middle. Right? There's a pericallosal that arises from the communicator, as well as an A1 and A2. And from each direction, there was one aneurysm sitting and another aneurysm sitting underneath it. And so if you didn't understand the anatomy, you would think that we were just filling the contralateral A2, when in fact, there are 2 different aneurysms pointing in 2 different directions. So here we're opening up the arachnoid again over the optic nerve, and then heading in the direction of the communicative complex. You can see the carotid there. And again, no retractors. This is just retracted with my sucker and pulling down. You can see Huber. And then getting back into the region of the complex. Here's the optic apparatus. Just draining CSF. You're beginning to see the first dome that's arising from the ipsilateral side.
Moving forward this morning.
This is just sort of looking underneath. Seems like it's a little out of focus. Putting a little temporary clip. And then clipping the aneurysm with a slightly curved clip. That original position, again, doesn't completely obliterate it, and I think we just adjust that a little bit. again, being cognizant of where the A2 vessels are. In this case, there are 3 vessels that you have to worry about. So that's, that first superior pointing dome. Now this is going after the other dome. So the other dome is pointing at us. You can see the contralateral A2, the neck of the aneurysm. Now this aneurysm is arising between that pericallosal that's arising from the complex and not the other A2. And so what you're seeing underneath, you're going to see in a second when I look underneath, is that pericallosal, and the clip isn't completely across. And so by looking and examining the position of the clip, you can see there's still some aneurysm there. And so you have to advance the clip a little bit. And again, still draining CSF in there. And then I use this micro Doppler probe that actually Johnny Delashard turned me on to. It's the device that the anesthesiologists use to put in an A line. There's a Doppler device that can help them put in A lines. And so if you take the needle out, you have this really tiny Doppler, which is really fantastic for aneurysm surgery. And so we did our angiograms from both sides that showed the aneurysm was clipped. I'll just show you one, actually I have 2 other videos and then we'll be done. I think we're ahead of schedule. So this is a patient that actually had an A1 aneurysm. These are tiny aneurysms, see them here, that are notorious for rupturing at a very, very small size. You see how irregular they look? That they're hiding directly on the proximal portion of the A1 and they point directly out of your line of vision. And it's very hard to see them. So here I'm retracting very slightly right on the, this is the common and the A1 takeoff, and you'll see a little bit of the aneurysm start to poke out. There it is. Okay? These aneurysms are notorious for rupturing at a very, very small size. And if this wasn't so small, I would have coiled it just because they're a pain to get to. So this is a technique you heard Luke Kim talk about yesterday. Here you put one clip, right, and here's a fenestrated clip going just on the medial side of the aneurysm. And that, all that is it's a space holder. So that clip is not clipping the aneurysm. It's a space holder so that when you put in the second clip, you'll see that it puts the clip right in the area that we want to look. You see the aneurysm is still right here, proximal to it, okay? And you can't see it so well, but there's some perforators deep to that. So you want to be careful. You see the perforators coming out. You want to be careful not to get those in the clip. And here's the second fenestrated clip, just that closes down the entire aneurysm, and then we'll take off that other clip. But the technique of you stacking clips or using a clip as a space holder is very useful. You can see the aneurysm is gone. I just want to show you. Let's see if we can show you. This one on the screen here. So this is actually for a 3D aneurysm. I'll tell you a little bit about this case, and then we'll, because it illustrates a lot of points that are useful in clipping aneurysms. So this patient actually had about just under a 2 centimeter isolated bifurcation aneurysm that I had coiled. And when I coiled it, she actually recurred, but recurred in the usual way. The neck of the aneurysm continued to grow, and it started to grow towards the A1 vessel. You see this was all sort of like new aneurysm formation in this area here. And so she was a young woman, originally didn't want to have an open procedure, but when the aneurysm recurred, I told her that this aneurysm was going to keep growing and growing, and she was going to need an operation. So initially I brought her into the operating room to try to directly clip it. You can't really see the dome of the aneurysm. Again, there's no retractors here, but there's a big mass of coil. So the first thing I've done is I've tried to expose the neck, and I'm just trying to put a straight curved clip on, slightly curved, and clip it directly. Okay? And so I'm cinching it down, and without doubt, you can see as I close the clip, I'm kinking the vessel there. kicking the M1. And that's not good. We know there's not going to be good flow there. So let's move it along a little bit. So here I'm exposing it a little more. You can see there's a temporary clip that I put down lower on the carotid while I was doing the dissection. And you can see there's a lot of coils in this area. So here's your A1 here. There's a little piece of gel film there on the A2. So I'm repositioning that temporary clip. You can take a temporary clip on and off if you want. So if you feel like you've had a temporary on too long, you can take it on, you can take it off and sort of reperfuse for a little bit. But here, I knew that those coils were going to be